All right. So this is the portion of the lecture on SIRS and mods. So a lot of what we're going to go over here is going to be very similar to all of the shock and sepsis that we've already talked about, but a little bit more detail, and I am going to go through this pretty quickly. As we think of SIRS, we are thinking about a systemic inflammation response to a variety of different things. So we're going to talk about these things here in just a second, but we're really focused on the inflammation that's going on in the organs. So a lot of the triggers are things having to do with either tissue trauma, microbial invasion, ischemia of some kind, or issues with perfusion. So when we think about tissue trauma, we have burns, crush injuries, even something as simple as like a surgery could cause this. We have our bacteria, viruses, fungi, that sort of thing. Uh, Ischemic tissue, that could be, even like we talked about with MI or something vascular related. It can be our pancreas. It could be some kind of abscess or ischemia of tissue from like a wound or something. And then we have shock type perfusion deficits. So then when you hear the term MODS, you want to think of failure of two or more organ systems. So no kind of homeostasis can be maintained without intervention here. So this is going to result from SIRS, and this is the more extreme once SIRS has progressed. So here's just a little visual of the relationship of shock, SIRS, and MODS. So we see our different kinds of shocks that are then leading us to the SIRS. So I won't read through all that for you, but really we're thinking about the vasodilation, the increased capillary permeability, leading to our edema. And then how it affects the organs is really what we're thinking about when we're thinking about MODS. So you can see obviously all the different organs that this can affect. So we have another case study patient. We're going to talk about KR. She's a 28-year-old woman brought to the ED by her mother with confusion, fever, and apparently she said she's had the flu for the past week. So she's been vomiting for a couple days, noticed some edema. So her vital signs, she has a temp of 103.5, heart rate is elevated at 112, respiratory rate is elevated at 24, and we see her low blood pressure of 88/54. So we'll kind of talk about her as we go through this. So we know I've said this so many times. We're talking about the inflammatory response. So those mediators are released, they're damaging the endothelium. Um, we're going to keep talking about the vascular permeability, and then we'll also kind of talk about the activation of our coagulation cascade and how that's going to impact how we treat these patients. So when we talk about SIRS and MODS both, we're still just seeing the hypotension, therefore decreased tissue perfusion, therefore the redistribution of blood flow, therefore the compromised organ perfusion. Same thing we were talking about with most of our sepsis and shock discussion. So when we think about the respiratory system, we see our alveolar edema, we have our decreased surfactant, all these things that happen when the respiratory system is not getting enough blood flow. As far as the cardiovascular system, our myocardial depression and massive vasodilation is resulting in decreased stroke volume and blood pressure. We have increased heart rate that's trying to compensate for our hypotension. And then obviously we know that our albumin and fluid are moving out of the blood vessels, and we can see dysrhythmias with this as well. Neurologic system, we're going to see a lot of confusion, agitation, combative, or sometimes lethargy based on our decreased perfusion to the blood or hypoxemia. As far as the kidneys, we're going to see AKI, obviously due to our hypoperfusion. And then the other thing to keep in mind when we're talking about our kidney injury, we talk so much about like decreased urine output, is that we have to worry about those nephrotoxic drugs. And what's one of the main drugs that we're using to often treat some of our main forms of sepsis, antibiotics, of course. So a lot of antibiotics are very nephrotoxic. So we really have to be careful that we're not making the AKI worse with the drugs that we are choosing. When we think about our GI system, we have that decreased GI motility. So we have to watch for abdominal distension, ileus, and then our decreased perfusion. So when we're not using the system, um, we don't have the blood flow. So we're going to have ischemic injury potentially, and then we'll see ulcers and GI bleeds as well. So I'm not going to go into this in too much depth, but we're really focused on that hypermetabolic state. We need to remember that our body is working so hard to try to compensate that we are in this hypermetabolic state. We will see DIC because of the dysfunction of the coagulation system, because of what's going on. We're going to see electrolyte imbalances, and then we're really going to see a lot of metabolic acidosis in these patients. So our patient here, KR, we got admitted to the ICU with a possible diagnosis of sepsis. Her urine output is low. She's only had 15 mils in the last 2 hours total. Amber colored chest x-ray shows bilateral infiltrates, white blood cell count, and lactic acid are high. So our prognosis for MODS is very poor. The goal really is to prevent it in general and to prevent any kind of progression as we get to it. So when we're taking care of patients with sepsis, with SIRS, just that monitoring, noticing the very early signs of any kind of organ deterioration is so critical, so that we can get that corrected immediately. So when we're thinking about our care for these patients, we're really focused on preventing the infection and then treating it if we do see it. We need to maintain the tissue oxygenation. We're going to continue to talk about and think about the nutrition and metabolic support. So for both reasons, one, because we know our bodies, our metabolism is increased because of everything that's going on, and then also because of all the complications that happen when there's no nutrition in the gut, like we talked about. So, and then just any other organs that you notice that are failing, just whatever appropriate support you would find with those. And we're not going to go through every little detail of that. A lot of it's stuff you guys have already learned. So our patient has a catheter inserted as well as a CVC. The doctor's talking about possibly putting her on a ventilator, and her mom is asking why she's so sick, what are we going to do for her? So as we talk about care for these patients, really strict asepsis for these patients, really assessing the need for any invasive lines that they have, and then real aggressive pulmonary management is super important. So using those incentive parameters, coughing, making sure we don't have some other kind of infection along with what's going on. So we certainly don't want to get a pneumonia when they already have something else happening. This could even include like aggressive surgery to remove any kind of necrotic tissue. And then just really broad spectrum antibiotics are going to be key here. Of course, we want to maintain our tissue oxygenation. So whatever we can do to decrease our O2 demand and increase our delivery. So sometimes these patients are going to be sedated and on a ventilator just to decrease the workload and allow the oxygen to be used in the most important areas. So obviously analgesia, rest, and then treating fever, chills, pain, because once again, those are increasing our O2 demand and our metabolism. So once again, nutrition, we want to preserve the function of our organs. So the more we can use them, the better. Our total energy is often increased 1.5 to 2 times. So we really need to get some nutrition into our body so that we can support those metabolic needs. Okay, our patient has developed petechiae and jaundiced skin. What do those things indicate? And what are some treatments that you would anticipate being done for her? So, jaundice, what are we thinking about here? What organ? So we're thinking about the liver, and we're thinking about our increased bilirubin. And then when we think about the petechiae, our first thought is probably going to be DIC. And so what's going on with our clotting here? So um, what are some treatment that we would anticipate? So remember what we talked about, where obviously priority is going to be the infection. So aggressive antibiotics. And then obviously we're focused on maintaining oxygen, oftentimes a ventilator, intubation, and then just keeping an eye on all those body systems. All right, so still thinking about supporting the failing organs. So if our patient is in ARDS, we're thinking about aggressive O2 therapy, we're thinking about ventilation. We need to be careful when we're using blood products because obviously we know that blood products are used in these patients, and when they are used, um, when we give too much blood products, do you guys know what's missing from the blood product? So we don't have anything to help us coagulate in the blood product. So if we infuse too much blood and then it gets mixed with the rest of the blood, obviously our coagulation factors are going to be lacking. So that's just something to keep in mind. And then renal failure and thinking through whether we need to do some temporary dialysis or something like that. Um, yeah, so this is serious. So once again, just communicating with family members about realistic goals and knowing that we may not be able to fully fix all of the issues once we've gotten this far. Okay, so just a few questions to review. Patient with a history of alcohol use is admitted to the ICU with hemorrhage from esophageal varices. Blood pressure is 84/58, heart rate 105, respirations are 32. The nurse recognizes the onset of SIRS upon which finding? So which one of these things is really showing that we have SIRS going on? So dysrhythmias, pulmonary edema, absent bowel sounds, or decreasing blood pressure? Pulmonary edema. Okay, a patient is admitted to the hospital from a long-term care facility, appears to be in the late stage of shock with SIRS. Which order implemented by the nurse has the highest priority? So do we want to put 2 IVs in, get a urinary catheter in, start normal saline, or apply oxygen for this patient? Okay, so the answer is D. Oxygen's going to come first. That's a super quick thing. We obviously know that our blood is lacking in oxygen, so that's going to be our first focus. And then obviously the IVs before we can provide fluids. So, okay.